A respiratory therapist working in the intensive care unit will usually have several ventilators that he's managing and monitoring. And every 4 hours, usually, it depends on the department policy, but usually about every 4 hours, the respiratory therapist is going to go around to each of his ventilators and do a very thorough check. And they often are called ventilator checks, vent checks. Monitoring the ventilator goes by a lot of names. The correct term is patient ventilator system checks, because we're not just checking the ventilator, we're checking the patient also, and everything between the patient and the ventilator, which would be the ventilator circuit, the humidifiers, the patient's endotracheal tube or tracheostomy tube, whichever he has. So the respiratory therapist is going to check also the alarms on the machine, making sure the alarms are set appropriate so the patient is protected in case there's any condition that might cause harm to the patient, or to alert you that some change has occurred in the patient. The ventilator check, the part on the ventilator, we want to make sure the ventilator is set according to doctor's orders, and we want to make sure that the patient is tolerating these settings on the ventilator that we've chosen, that is to ventilate the patient. So let's continue on here. Let's begin by the what's called the view from the door. When you're entering the patient's room, there's a lot that you need to be aware of when you're doing this. Just entering the room, you always want to make sure you read the chart, the electronic medical record. Make sure you know what the doctor's orders are, and you want to check and make sure you go in there and do all your charting and everything, and then you come back out and you find that the doctor had written an order to make some change on the ventilator, and now you got to go back in and do that. So you want to make sure you know what the doctor's orders are, what the current doctor's orders are. It maybe the patient has had an x-ray since the last time you looked at his chart, and so you would want to look at his x-ray and see if there's any changes in that. Of course, you want to clean your hands and put on gloves, and if the patient's in any kind of isolation, you want to put on the appropriate PPE. And as you go into the room, this is where the view from the door is a very important concept. From the door, as you're walking toward the ventilator and the patient, you learn to do this very quickly. You want to look at the bedside monitor and see what the patient's heart rate, blood pressure, his body temperature, his O2 sats, all this information on that monitor is very important. And you want to kind of make a mental note of what these things are, especially heart rate and blood pressure. Let's say you're monitoring the patient's ventilator and the alarms start going off, and you look up and his heart rate is 110. Well, did it go up? Well, you won't know if you didn't look at it before. So if, when you walk in the room, you see his heart rate's 110, the alarms are going off, you look and see it's 110. Or if you walk in the room and the heart rate is 70 and the alarms are going off and now the heart rate says 110, that would indicate a more serious problem that you need to try to figure out what that problem is. And when you're doing these ventilator checks, you're being a kind of a detective. You're looking for clues. You're looking for indications that something might need to be addressed. So besides looking at the monitor, you look at things like hanging from the bed, like the chest tubes. And does the patient have a chest tube in the right side, the left side, both sides? You want to look at urine bag. There'll be a urine bag hanging on the bed. You want to look to see if it is, straw colored and plenty of urine in there. That would be normal. If it's dark, that could indicate some liver problems. If you have a trauma patient, you might see blood in the urine. Those are all significant things that you need to know about. Also, what if you see that the urine bag is completely empty? Well, that could mean that the patient is not making any urine, and that's not good for a patient on a ventilator, or any patient not making urine. And so you would want to ask the nurse about that. You ask the nurse, what's the patient's I's and O's? That means his in and out fluids. And we don't want to have a patient who has a positive fluid balance that puts him into pulmonary edema. So you ask the nurse, and maybe the nurse will tell you, well, I just emptied it. And that would be another reason why the bag would be empty. Anyway, the patient's urine output is an important thing for the respiratory therapist to know about. And you want to look, often there'll be a sign above the bed on the wall that might say something like no blood draws, right arm. Well, you go in there to do a blood gas and you stick him in the right arm, and then you look up and see that sign, you say, uh-oh. So also the wall sign may say something about the patient should be flat in bed, some spinal cord problem, or it might say C-spine precautions. Whatever it is, you might, you want to check and just kind of scan the walls, see if there's any signs there that warning you about something that you may need to know about. You want to talk to the patient. If the patient is not responsive, if he's on the ventilator and he's chemically paralyzed or heavily sedated or comatose or whatever, I still like to talk to the patient anyway. Let him know I'm the respiratory therapist and I'm checking your ventilator or something like that. You may have a patient who is awake and looks at you, and he's on a ventilator. He's in the intensive care unit. He's probably worried, and everybody comes in the room. He really wants to know what that's about. So you explain to him that you're the respiratory therapist and you're just doing your routine checks with your machine, just making sure it's doing what it's supposed to be doing, and not to be concerned about it. Also, you may want to ask the patient, how's your breathing? We're checking the ventilator, make sure everything is set right for the patient, but the ventilator doesn't tell us all there is to know. We can ask the patient, how is your breathing? And the patient may indicate that his breathing is good, that's okay, or that it's not good. He may indicate to you that and he needs more ventilatory support. So it's very important to communicate with the patient. I went into a patient's room one time. He was sitting up in bed. He was very alert. He had a trach, and he was, a chronic patient of don't remember what. And I said, how's your breathing? And he indicated his breathing was good. His mother was standing right behind me, and she says, he's been here for a week and nobody's asked him that. Well, somebody should have been, asked him, well, how is the machine working for you, rather than just looking at a bunch of numbers on the machine. So let's first talk about the ventilator. We're going to check the ventilator, and we're going to document all of this stuff that we see on the ventilator. We're going to monitor for the settings on the ventilator, what is set, and that should match exactly the doctor's orders. So what's on the ventilator should match exactly what you're documenting, which should match exactly what the doctor's orders are. So in the first section, when you're monitoring the ventilator, you will have what is set on the ventilator. So you want to indicate what the volumes are, and the volumes we're concerned about is the tidal volume and the minute ventilation, of course. And our ventilator will tell us the inspired tidal volume and the expired tidal volume, and those should be the same, right? If you have a patient getting a 500 tidal volume in, he should exhale 500 tidal volume. And what would it mean if you see 500 inspired and only 400 exhaled? Well, that would indicate that you got some kind of a leak in the system, probably. Now, you also want to look to see that that's happening every breath, because sometimes a patient will not exhale completely, or one breath, and then exhale more than he inhaled on the next breath. So you want to see that it's consistently tidal volume lower than the exhaled tidal volume lower than the inspired tidal volume. And so then you got to put on your Sherlock Holmes hat and try to figure out why that is happening. Very often that is that the cuff on his ET tube needs to have some air added to it. it's not sealing the airway very well. And so the ventilator delivers 500, but all 500 doesn't go into the lungs. 500 of it may leak around his tube and go out into the room. So then when he exhales, you only see 400 being exhaled. Another problem could be related to those chest tubes. Remember when we walked in the room and we saw chest tubes? He may have a bronchopleural fistula, and the patient gets a 500 tidal volume, but 100 goes out his chest tubes. He has a large bronchopleural fistula. And so that would explain where that tidal volume is going to. Now, in some cases, you may want to increase the tidal volume on his ventilator to 600 to make sure he gets 500, but that's on a case-by-case determination. So at any rate, you need to be a bit of a detective here and try to figure out what is happening to that tidal volume. What would it mean if you saw that the patient was inspiring 500 and exhaling 600, and he's doing that every breath? That would be kind of a difficult thing to do unless the patient is manufacturing air in its lungs. You can't continuously exhale more than you inhale. And when you see that, that's not a common one, but you may see that, and that usually is a problem with the ventilator. You see the inspired tidal volume, that's probably accurate because that's on the dry side of the ventilator. The inspiratory side of the ventilator, there's no moisture in there. The expiratory side, the patient exhales humidified warm air into the ventilator. And there should be an expiratory filter, and that will get some of the moisture out. Some expiratory filters on some ventilators are heated so that it's pretty much dry air, or much drier air going back into the machine. But that moist air can affect the expiratory transducer and have it tell you something that's incorrect, that the tidal volume is more than what it really is. Anyway, again, you got to be a detective. The other volume we want to look at is the minute ventilation. And of course, that's the tidal volume times the respiratory rate. And we get the minute volume, otherwise known as the patient's ventilatory demand. The ventilatory demand is the amount you need to breathe per minute to make your CO2 normal and your pH. So if you look and see that the minute ventilation is more than 10 liters a minute, that's an unusually high ventilatory demand. So again, you would want to try to figure out why is that? Why is he breathing more than 10 liters per minute? Metabolic acidosis would account for that. You know, a patient has metabolic acidosis, he's going to try to correct that pH by breathing deeper and faster and have an increased minute ventilation. He could have a disease process going on that it increases his dead space ventilation. And the patient could be hypermetabolic. You go into the burn unit and you see patients in there producing 2, 3, 4 times the normal amount of CO2 per minute. So anyway, you just got to think about why that minute ventilation is so high. And also when you have a patient in SIMV, probably some of his breaths are mandatory mechanical breaths from the machine, and some of his breaths are the spontaneous. And so the machine is going to tell you the total exhaled minute volume, combining the spontaneous breaths and the mechanical breaths. Another thing we need to measure on our ventilator is the pressures. And there's several pressures we want to look at. First of all, we're going to probably look at the peak inspiratory pressure, or PEEP, PIP. That's what people call it, the PEEP. But you may see it on your ventilator reported as the PAW. That's the pressure at the airway. They all mean the same thing. And that's the highest pressure during inspiration. And it's almost always going to be at the very end of inspiration. You know, the ventilator is delivering a breath to the patient, and as the air goes into his lungs, the manometer is going to show the pressure is going up and up and up. And at the very end of inspiration, when the expiratory valve opens, that pressure falls back down. So we're looking at the peak inspiratory pressure, and we're going to document the peak inspiratory pressure. So how much pressure does it take to put in a 500 tidal volume? Well, it depends on the patient, right? It depends on the airway resistance and the patient's lung compliance and chest wall compliance, how much pressure that takes. So that peak inspiratory pressure is the pressure to overcome resistance of flow through the airways and the pressure that it takes to distend the lung to fill the alveoli. To tell the difference between how much of that pressure is to overcome resistance and how much to overcome the elastic forces of the lung, we do a maneuver called inspiratory hold or inspiratory pause. And to get this, what we do is we have a button on our ventilator that we push and hold, or some ventilators you don't have to hold it, but you press that button, and what it does is it's after the breath is delivered to the patient, instead of letting the patient exhale, it doesn't let him exhale. So it closes both the inspiratory and expiratory sides of the machine. And so you get a static measurement, a measurement with no flow. And that is called the plateau pressure. And now that is going to be alveolar pressure. What we're seeing is airway pressure. That's what we're measuring during the plateau. But with no flow, airway pressure and alveolar pressure should be the same. Because remember, in order to have flow, you have to have a pressure gradient. The pressure has to be higher at point A than point B for air to flow toward point B. And so if there is no pressure gradient between point A and point B, then the pressure is the same at A and B. And the same with the airway. If we stop flow and we see the pressure at the airway, that is going to be the same pressure at the alveoli. And that is the pressure we're really concerned about with our ventilator patients. And the plateau pressure is going to be something that you should be measuring every time you go in and check your ventilator. One thing you want to see if it's trending upward or trending downward. If every time you go in and see the ventilator, the plateau pressure is higher and higher, that could indicate something is going on with either his air with his fluid balance. He might be becoming fluid overloaded. He could be developing atelectasis. He could have more consolidation. A lot of things that could be, but we need to notice that it's trending that way, and then try to figure out what the problem is. You might want to look at the X-ray, talk to the doctor, figure out why the alveolar pressure is increasing. And we want to keep that below 30 centimeters of water pressure. There's been many studies showing that patients have better outcomes if we keep that pressure below 30 centimeters of water pressure in all of our patients. Another pressure we're going to look at is the expiratory pressure. When the ventilator delivers a breath and the expiratory valve opens, the pressure falls back down to a baseline pressure. Now that might be 0 if we have no PEEP set on our ventilator. And when we say 0, it's not an absolute 0 pressure. That's atmospheric pressure or ambient pressure. But most of our patients are not going to have a 0 expiratory pressure set on their machine. We are going to set a PEEP level on our ventilator. And what the PEEP does is it prevents the pressure from falling down to 0. So say, for instance, if we have 5 centimeters of PEEP, then after inspiration and exhalation begins, the pressure only falls down to 5. So that will increase the end expiratory lung volume. You know, the end expiratory lung volume, we usually refer to that as the FRC, the functional residual capacity, and it usually is. End expiratory lung volume is more accurate, but you'll often see and hear people refer to it as the FRC, and that's okay. So if we have a patient who has some collapsed lungs, some atelectasis, and we increase the PEEP, hopefully that will open up some of those alveoli and will improve oxygenation. So when we have a patient on the ventilator and he requires a high FiO2, and that often means that we need to increase his PEEP to improve oxygenation so we can turn his FiO2 down. And more about PEEP as we go along here. Another setting on our ventilator is called the sensitivity, and that's about triggering the ventilator to deliver a breath. Whatever it is that starts inspiration, we call that the trigger. So a ventilator may trigger in different ways, so depending on what we have set and depending on the patient, but it may be time triggered. In other words, let's say we have a patient on the ventilator and he's getting 12 breaths per minute and he's not breathing. He's either comatose or paralyzed, heavily sedated, whatever. He's not breathing and he's in assist control. And at 12 breaths per minute, that means he's going to get a breath every 6 seconds. So the ventilator gives him a breath, and then when his 6 seconds is up, he gets another breath. So what starts inspiration in that situation would be time. A certain amount of time goes by, the ventilator gives a breath. Time goes by, the ventilator gives a breath. And so those are machine triggered or time triggered breaths. Now we may have a patient who's breathing, interacting with the ventilator, and he is triggering breaths, patient triggered breaths. So it's not an amount of time, it's just when the patient wants to take a breath, he makes an inspiratory effort and triggers the breath. Now we can do that in two different ways. One is pressure triggering, where we set a pressure of like -1 or -2, and that's below the baseline pressure, below the PEEP. And when the patient makes an inspiratory effort in a closed ventilator system, the circuit is a closed system, if he makes an inspiratory effort, he tries to suck in a breath, it's going to cause the pressure in the circuit to go down. And when it goes down, if you have it set at 1 centimeter water pressure, the pressure goes down 1 centimeter water pressure, the machine knows that the patient is initiating a breath. So the machine gives him a breath instantly. So he gets an assisted breath. We call that an assisted breath. Now, that imposes some work on the patient. If we set it at 1 or 2 centimeters water pressure, the patient has to generate that much negative pressure to get the ventilator to start giving him the breath. So that is an imposed work on the patient. It's a small amount of work. It used to be more work in the past, but now our ventilators are much more sensitive than they used to be. And so the patients trigger the ventilator pretty easily. And because our ventilators are more sensitive, they're also more responsive. You have two things here that you have to think about in ventilator triggering. The sensitivity, and that's how sensitive the machine is to sense that the patient wants a breath. And the responsiveness is how quickly the ventilator can deliver that breath once it's triggered. And so today's ventilators with microprocessors, they're very sensitive, they're very responsive. Another way that, and what you'll see most often on ventilators today, is called flow trigger. With flow trigger, the patient doesn't have to drop the pressure in the circuit. He simply has to he just begins to breathe in. And with flow triggering, there is a constant flow of air through the ventilator circuit. Even when there is no inspiration or expiration between the breaths, there's this bias flow, they call it, or base flow. And that flow is a low flow, and it's going through the circuit, and the patient starts to breathe in. He takes some of that flow away. And so the machine senses that the flow decreased because the patient's taken some of it, so it gives him an assisted breath. So with flow triggering, there is no imposed work on the patient. As soon as he starts to breathe in, he starts to get air. He doesn't have to open a valve inside the machine with his inspiratory effort. And that's the most common way we ventilate patients today, is with the flow trigger rather than the pressure trigger. Auto triggering is something that we don't want to see on our ventilator. Auto triggering means that for some reason the sensitivity is too sensitive, and the machine thinks the patient is making inspiratory efforts, and it starts giving him all these extra breaths. And that can be dangerous to the patient because it can cause a severe alkalosis or respiratory alkalosis, blowing off too much CO2, that, giving the patient a whole bunch of breaths and increasing his minute ventilation, sometimes pretty dramatically. It also can cause air trapping, so the patient may not finish exhaling when the next breath is auto-triggered. So we need to be careful about auto-triggering, be able to recognize it. Sometimes it's not real noticeable, but the machine will tell you every breath that is triggered by the patient. So you can look and tell which breaths are patient triggered and which breaths are machine triggered. When it shows the patient is triggering and the patient is paralyzed with neuromuscular blocking agents, that means one of two things. One, the drugs are wearing off and he's starting to breathe, or the machine is auto-triggering. So it's not always real obvious it's auto-trigger. You need to look for that and always be aware that could be happening. Now here we have what is called a waveform, ventilator waveforms. We can see pictures of breaths. We have waveforms that they're called scalar waveforms, and we plot on this axis a respiratory parameter. In this case, we got pressure, but that could be the volume, the tidal volume in and the tidal volume out, and it could be the flow going in the patient, and the flow coming out of the patient. Here we're looking at pressure. And we see here's where the breath began, and this is a volume controlled breath, and say we're putting in 500. So as the air, this is time right here. So this is 1 second is from here to here. We'll say this is 1 second. The inspiratory time in this breath is 1 second. So the machine delivers a breath, and the pressure goes up and up and up until the breath is delivered. And then the machine opens the expiratory valve, and the pressure should come right back down, in this case to 0, because there's no PEEP. But you can see on this breath what we do after an inspiratory time is set at like 0.9 seconds. We do an inspiratory hold maneuver. So we stop flow. So the pressure falls down to here. This is the static pressure. This is a pressure with no flow. This is the plateau pressure. This is alveolar pressure. So remember, there are two forces that oppose inflation of the lung: the resistance of flow and the pressure, the elastic forces of the lung resisting the distension of the lung and the chest wall. So when we do the plateau pressure, we know this is alveolar pressure, and we want to keep that below 30. In this case, it looks like it's about 35. So maybe we don't need a 500 tidal volume on this patient. We need to turn his tidal volume down because we're getting up into dangerous territory with a plateau pressure that high. So the pressure to deliver this breath, part of it was to overcome airway resistance, and part of it was to overcome elastance. And we can see the difference right here because the pressure from the plateau pressure down to the baseline pressure, that's the amount of pressure it took to distend the lungs. The pressure between the plateau pressure and the PEEP is the pressure to overcome airway resistance. Now, if we look at this scalar waveform, pressure again, it looks kind of similar, but there's some significant differences here. One, when the breath starts and when the breath ends, we can see that the pressure is 10. So that means this patient has 10 a PEEP. See, his inspiratory pressure is PEEP. So when he exhales down to 10 centimeters of water pressure. So this patient, again, this guy is going to a peak pressure of 40, plateau pressure is 30. Now the difference between the PEEP and the plateau pressure, remember, that's to overcome airway resistance. And this is, you're going to learn about these trans pressures, but this is the trans airway pressure. This is the pressure difference across the airways. So this is one end of the airway is at the end of the ET tube, the proximal end of the ET tube, and this pressure, this is, remember, the alveolar pressure. So we're seeing the difference between these two pressures, so we know what that pressure gradient is, and that pressure gradient is called the trans airway pressure. Now, let's look back here at the beginning. He's got 10 a PEEP, and he makes an inspiratory effort. I can tell he initiated this breath because see how the pressure went down? And if his sensitivity was set at -1, then when that pressure gets down to 9, the ventilator knows he's trying to take a breath. So you can see the drop in the pressure and the breath is triggered and gives the patient a breath. So this is an assisted breath. It's a mandatory breath, and the patient triggered that breath. That's a patient triggered breath. And the trigger was probably pressure triggering. And then we did the inspiratory hold for looks like about 1 second, and then let the patient exhale back down to his 10 a PEEP. Now what happens here? The pressure goes down like the patient's making an inspiratory effort. And indeed, that's what is happening. The patient's making an inspiratory effort. Why didn't he trigger a breath? Well, he didn't trigger a breath because this patient is in SIMV. So remember, in SIMV, you have mandatory breaths and you have spontaneous breathing. So after his mandatory breath, the patient wanted a breath here, so he took a breath in, and then the pressure goes up slightly when he exhales. So this is what pressure looks like when the patient's breathing spontaneously on the ventilator. Kind of makes a sine wave. The peak flow is in the middle of inspiration, and so the biggest drop in the pressure will be in the middle of inspiration. So this is a patient on a ventilator with 10 a PEEP. We can't tell his tidal volume here because volume isn't on this axis. His peak pressure is going to 40. His plateau pressure is 35. He's in SIMV, and during his spontaneous breath, the pressure did not go up. So this patient's not getting any pressure support. So SIMV with no pressure support. So another thing we need to check on our ventilator is the alarms. The alarms are there to protect the patient. So we know if there's any kind of a change or problem occurring with the ventilator. And ventilators have lots of alarms. All ventilators have alarms for volume, and all ventilators have alarms for pressure. And some ventilators have a lot more alarms than that. Some only have a few more. The ventilator manufacturers put whatever kind of alarms they want in their ventilator. And usually today, most ventilators have alarms covering just about any kind of problem that could occur. We're going to have a pressure limit alarm. And the pressure limit alarm is very important. This is what protects the patient from high pressures. So we're going to usually set the high pressure limit at about 10 above the peak inspiratory pressure. So if his peak inspiratory pressure is going to 25, we would appropriately set the high pressure alarm 10 above that at 35 centimeters of water pressure. Now, that alarm can sound for quite a few different reasons. What if the patient coughs? He's on the ventilator and he coughs. Well, it can make that pressure jump up and hit the pressure limit. It could be the pressure is gone up because he needs to be suctioned. He's got a lot of secretions in his airway obstructing the airflow. It could be that his lung compliance fell. What if he developed a pleural effusion, atelectasis, pneumothorax? Any of these things that causes compliance to change will cause more pressure needed to deliver the breaths. There could be a kinked ET tube. The patient could be biting on his ET tube. The ET tube could be obstructed with what we call a biofilm that develops inside the lumen of the endotracheal tube. And over time, that can build up and cause some obstruction of the tube. It could be because maybe his humidifier isn't functioning properly and his air that he's breathing is too dry and causing crusting of the inside of the ET tube. That's a term that's used when you get a buildup of this biofilm or inspissated secretions inside the ET tube. And he could have coughed and got a big plug that is obstructing the ET tube. So those are all kind of things that could cause the high pressure alarm to be going off. Now, it may be that the patient is just fighting the ventilator. He's trying to exhale when the ventilator is giving him a breath, and he's very uncomfortable and agitated, and could be causing the alarms to go off. A very important thing to consider about the high pressure alarm is that when it reaches that pressure, the machine will make a sound, an alarm sound, and it aborts inspiration. So that when it hits that pressure, the pressure won't go any higher. The machine is going to stop inspiration. So say, for instance, your patient is coughing a lot. Every time the ventilator starts to give him a breath, he coughs, and he may not be being ventilated. The high pressure limit could be reached at the end of inspiration. He got most of his tidal volume, or maybe he only got half of his tidal volume, or maybe almost none of his tidal volume. If it's pressure limiting, like with a kinked tube, it will pressure limit, pressure limit, pressure limit, and the patient not being ventilated. So all ventilators have a high pressure limit alarm. Some, not all ventilators, have a low pressure alarm. So if the pressure is going to a certain pressure every breath, and suddenly there's a big leak in the circuit, or the ventilator comes disconnected from the patient, the machine may not recognize that. So with a low pressure alarm, the machine knows, well, it didn't reach that pressure that you had set. So that could be caused when there's a leak in the system or patient disconnects usually. And you're usually going to set that about 5 to 10 centimeters below the peak inspiratory pressure. Not all ventilators have that alarm. If we have our PEEP set at 8 and for some reason there's a leak around, cuff leak around his tube, or whatever, some reason that PEEP is not being held, we get a low PEEP alarm. Or if the patient's in CPAP, it'll be a low CPAP alarm, but usually it'll say low PEEP CPAP alarm. And that's often because of a leak. And that should be set appropriately. We usually just set that a couple above and a couple below the PEEP level that is set on the ventilator. So there's a bunch of other alarms. There's an apnea alarm, and the apnea alarm alarms when the patient stops breathing. So say, for instance, we're doing a spontaneous breathing trial on a patient, and we take away all the breaths per minute from the machine, so he's just breathing on his own in CPAP or with a very low level of pressure support, testing to see how his breathing is. And let's say he goes apneic, well, there's going to be an alarm. Now, when we set that apnea, we are going to set an apnea interval, and usually on adult patients about 20 seconds. So if there's no breath of any kind for 20 seconds, the machine will alarm apnea. Now, our older ventilators would alarm and just keep alarming until you went and assess the problem. Today's ventilators, though, we set an apnea backup. So we set the settings that we want to ventilate the patient with in the apnea backup settings. And if the patient goes apneic for 20 seconds, it goes into apnea ventilation, and the patient is ventilated by the ventilator. And some ventilators, you have to go and take the patient out of apnea ventilation by pushing some buttons on a machine. Other ventilators will go back to letting the patient breathe spontaneously if he starts breathing. So, you need to know the ventilator, the brand of ventilator you're using, and how the apnea works on it, and all the details about it. There's going to be a tidal volume alarm on a lot of ventilators, and if we want to protect the patient from all of a sudden having lower tidal volumes than we want him to have, we're going to set an alarm at about 10 or 15% below the set tidal volume. Some ventilators have a high tidal volume alarm and a low tidal volume alarm, and some ventilators have a high minute ventilation alarm and a low minute ventilation alarm. So if the patient starts breathing a lot more, we're alerted to that, or if his minute ventilation drops. Some ventilators have a high and low respiratory rate. And so the patient starts, you got it set at 30 and he starts breathing 30, well, you get an alarm that he's breathing fast. Or if you set a low respiratory rate and he starts breathing like 8 breaths per minute, and you get the alarm set at 10, then you'll get an alarm, let you know that that's happening to the patient. Other alarms are like low gas source. If all of a sudden there's no compressed air or there's no oxygen, your machine should indicate low air pressure or low or no O2 pressure. The ventilators have an oxygen analyzer built in. The old ventilators did. You had to attach an oxygen analyzer. And the built-in oxygen analyzers tell you with an alarm if the analyzed O2 is off by 5%, above or below. And these ventilators today are very precise with the concentration of oxygen being delivered to the patient. The hoses come into the back of the machine, the two high pressure hoses, air and oxygen. And the first thing they come to is a mixing chamber where the gases are mixed to deliver the FiO2 you have set on the ventilator. And those are very precise and very accurate. Usually when you get the alarm that the oxygen analyzed is too high or too low, it's because the oxygen analyzer inside the machine needs to have the battery changed, the fuel cell. And then, of course, there's if the ventilator just fails, you will get an alarm, ventilator failure. Now, all of our modern ventilators have a internal safety valve. So if the ventilator fails for whatever reason, a valve opens so the patient can't breathe in and out. Now, he's going to be breathing a lot of CO2 perhaps, but he's not just totally locked out from the ventilator. And these alarms need to be responded to pretty quickly because some of them can indicate a very serious problem that you need to fix right away, or at least be that Sherlock Holmes detective and get in there and figure out what is going on that's causing these alarms to go off. Now, when an alarm sounds, you first want to check and see what that alarm is, but you can't spend a whole lot of time trying to figure out what the alarm is when the patient's blood pressure is dropping and his heart rate is going down and his sats are going down and he's in a serious condition, and you're looking at all these places that could be causing the alarm to go off. You need to make a very quick assessment, like 5 seconds, and determine if you can determine what's causing the alarm to go off almost immediately, you can fix it and everything's fine. But especially if you have a patient who's deteriorating, you want to take the patient off the ventilator and bag them. And when you take your licensure exam next year, that question is going to be on there. You're going to have a patient who is on the ventilator, the alarms are going off, and his blood pressure is going down. And the correct answer is you take the patient off the ventilator and bag the patient. Then another thing you want to do is when you're checking for the alarm cause, you start at the patient. You check the patient, especially at the ET tube. Is he biting on his ET tube? Has the ET tube migrated down to the right main stem? Is it got kinked or plugged up? The cuff blown, or whatever the reason is. And then you work from the patient, and you might listen to the patient's lung sounds also with your stethoscope while you're there. But you check the patient, that end first, and then you look at the tubing, make sure all the connections are tight, the humidifier back to the ventilator, and that's the way you're supposed to do that check. I was once paged to come to respond to an alarm, and I could hear in the background, the nurse paged me. I was in the ICU next door, and the nurse paged me and told me that the alarm is going off and driving everybody crazy. I need to come fix it. So I hurried over, and I walked in the room, and the nurse and another nurse and a doctor were looking at the machine, which was alarming like crazy. And as I walked in the room, I saw that the patient was almost completely extubated. Could see the cuff in his mouth, the tube sticking out, down to his chest. But the alarm was from the ventilator, not the patient. So they were paying attention to the ventilator. And that wasn't a problem, it was the patient. So remember, start at the patient and work toward the ventilator. Another instance that happened around that same time was a patient who was setting off the alarms on his ventilator continuously, and they had him tied down, and they were saying the patient was bucking the vent. He's fighting the ventilator. And so I went in and did my check when I first went up there to see what the problem was with him fighting the ventilator and if there's anything that could be done. And I discovered that the expiratory valve inside the ventilator was stuck, and so the patient could not exhale. So in this situation, it was the ventilator, not the patient, but everybody was blaming the patient. So just remember that it's the patient and the ventilator, and either end could be the problem. Start at the patient and work toward the ventilator. You have patients sometimes that set off alarms pretty frequently, coughing, agitated or whatever, or maybe just only occasionally alarm goes off for some reason. And the patient on the ventilator, he doesn't have much experience with this. He's probably never been on a ventilator before. He knows he's in the intensive care unit. He's critically ill. He's connected to a machine. He knows that's life support, and it's alarming, and nobody seems to be concerned about it. Well, that could be very worrisome for the patient. So just take a minute to reassure the patient that the ventilator is very sensitive and has a whole bunch of alarms on it that go off for nothing serious, and that he should not be concerned about the alarms, that we are paying attention to it. Another problem with alarms is what they call alarm desensitization. You're working in an ICU, and somebody is suctioning a patient in bed 2, and the alarm starts going off. And then somebody in the bed 4, they're turning the patient to his side, and he starts coughing and setting the alarm off. And then all these things the alarms are going off, but there's nothing really going wrong with the patient. And then in bed 6, a patient comes disconnected from the ventilator, a very critically ill patient who deteriorates really quickly when he comes disconnected. He comes disconnected from the ventilator, and the alarm starts going off, but nobody responds to it quickly because we've been desensitized to all these alarms going off all the time in the ICU. So one thing that you can do to help keep and we call those nuisance alarms, we want to make sure that when we suction our patient, we know the alarms are going to go off. So before you suction, push the alarm silent. So you get 2 minutes of alarm silence. The alarms are going to be going off. He's going to be coughing and all this kind of stuff. So try to avoid nuisance alarms. Another problem with alarms is that there is a volume. You set the volume for the alarm. And there has been cases where patients had really bad outcomes because they came disconnected from the ventilator and the alarm was set too quiet, and nobody at the nurse's station heard the alarm going off. So you want to make sure your alarm is loud enough. Some of our ventilators have alarms that are loud and obnoxious sounding. And some of our alarms on our ventilator sound like a song somebody's playing or somebody tuning a guitar. And they have studied that, and they found that the alarms that are more easy to listen to, the more musical sounding alarms, get ignored a lot more than the loud, obnoxious sounding alarms. Now, if you're working in a neonatal nursery, you need to be aware that these loud alarms are not good for babies. These babies need a lot of sleep, and if their sleep is disturbed frequently by loud ventilator alarms, they don't thrive. They don't gain weight. They don't do well. So that's another situation where you have to be very aware of the alarms and the alarm volume and the sounds of the alarms. Now, the ventilator circuit, that's another thing we're going to be checking when we go in and do our ventilator patient system check. So we want to check all the connections, make sure that the hoses are all connected everywhere, good and tight. And we want to look at the position of the tubing. We don't want the tubing laying across the patient's chest. Patients who are on ventilators are almost always restrained. Their hands are tied down to the side of their bed because, they're getting lots of drugs and they're sick and they may not be thinking too clearly. They don't know what's going on. They kind of wake up and something is stuck in their throat and they need to pull it out, and they reach up and they extubate themselves. And that can be very dangerous for patients who extubate themselves. So they keep them tied down. Now, if the ventilator tubing is laying across the patient's chest and his abdomen, where he can get his hand on it, he can grab the ventilator tubing and pull and extubate himself or disconnect the ventilator or cause something that could be harmful to the patient. So we need to position the tubing up where the patient can't reach it. We also want the tubing so that it's not pulling on his ET tube. So we have little holders for our tubing so that there is no traction on the patient's airway. We want to check for condensation in the tubing. If there's a lot of water sloshing around in there, we need to drain the water out of the tubing. We used to have a lot of problems with condensation in the tubing before we invented, somebody invented heated wire circuits. And the heated wire circuit is going to help prevent all of this rain out in the humidifier. And we'll talk about that here in just a minute. The proximal airway temperature should be, we almost always set it at 37 degrees, body temperature. So we get absolute humidity that results in 100% relative humidity. And at 37 degrees, if the patient's body temperature is 37 degrees, we should be delivering optimal humidification to the patient's airway, which is very important. Now, we don't want to set it higher than 37 degrees. We could cause airway burns, and that is not good. We don't want it set too low either. They've shown that less than 30 degrees, then you cause inspissated secretions. That means that secretions have had moisture sucked out of them, so now they're real thick and sticky, and that is not good. It causes mucus plugging and atelectasis and pneumonia. So generally, we're going to have it set at about 37 degrees. Now, as I said in the past, we had problems with water sloshing around in the tubing. And with a heated wire circuit, the way that works is that there is a wire that is on the inside of the circuit that is warm. It's warm because there's a small current of electricity passing through it, and the friction of the electrons going through that wire cause it to cause heat. And so the ventilator tries to maintain the temperature in the tubing at 37 degrees from the humidifier to the patient. That way there's no drop in the temperature, which would cause the air that is 100% relative humidity to rain out, because the cooler the air, the less water it can hold. So you get all this rain out. You want to be very careful, though, to not believe that the circuit should be dry. The circuit should not be dry. If the circuit has little droplets of water, fogging, any sign of moisture on the inspiratory limb of the circuit all the way to the patient, means that you have 100% relative humidity. If it is dry on the inspiratory limb of the circuit, all you know is that the relative humidity is between 0 and 99, because there won't be any rain out until it gets to be 100%. So always make sure you have some sign of moisture in the inspiratory limb of the circuit. And you can make adjustments on your humidifier if you need to do that. Now, another problem is you have the heated wire circuit, and you see a lot of water sloshing around in there. Well, then again, you need to adjust the chamber temperature on your humidifier. Don't think that you should have a dry circuit. People that think that run the risk of having severe problems happen to your patient. What if it's dry and the humidifier seems to be set appropriately, but then you notice that there's no water? You know, most of our ventilators today regulate the flow of water into it and will alarm if it runs out, but not all of them do. So if it runs out of water, then the patient's being ventilated with dry, heated gas, and that can cause permanent structural damage to the mucosa in a very short amount of time. So you want to understand the heated wire circuits in more detail than just, well, it prevents condensation, because that's a wrong way to think. Sometimes we won't have an active humidifier. We'll have a heat moisture exchanger. Those have been shown to work just fine during surgery and in patient transports. When you go from one part of the hospital to another, you don't have to carry all that water and the active humidifier on your transport ventilator. But some places, they use the HME on all of their ventilator patients. I'm sure you've all learned about HME by now. You know, the HME collects the moisture and heat from the exhaled and gives it back on the inhaled flow of gas through the HME. And the good ones are about 70% efficient. So that means you have a humidity deficit when you're using one. But if it's not much of a humidity deficit, it should be okay. But it's also recommended that you not use it for longer than 4 days, and then it needs to be changed to an active humidifier. There are contraindications, and if you're working at a hospital where they use HMEs, you need to be very aware of these contraindications. If the patient has bloody secretions, copious or thick tenacious sputum, he can cough that into the HME and plug it up, and so he's not being ventilated very well. I've seen that happen. You don't want to use it on a patient whose core temperature is less than 32 degrees. If the patient's hypothermic, we need to try to help warm him up with our humidifier, not maintain a core temperature of 32 degrees. Because, you know, when you breathe in air that's room temperature, say 21 degrees, and you exhale air that's 37 degrees, you have a net loss of heat. So if you have the temperature set at 37 on the ventilator, he's breathing in air that's 37, exhaling air that's even less than 37. Well, he doesn't have any net loss of heat. He can actually gain heat, and so that's a reason why we don't want the patient's core temperature less than 32 degrees. And you'll have patients like that. They often are found down, and they're very hypothermic. If there's a big cuff leak means that the air went down the ET tube, leaked around the cuff, and a significant amount leaks out into the room. Then the patient exhales what's left. He doesn't exhale all of his moisture back through that tube. He exhaled it out into the room. So if there's a cuff leak of about 30% of the tidal volume, HME is contraindicated. Patient with a large minute volume, remember, it's only about 70% efficient. So the bigger the minute ventilation, the more the humidity deficit. And when you're given any kind of medication through the ventilator circuit, you either want to bypass the HME or remove the HME and put it back in after the treatment, because the medication can cause the HME to have some sticky substances on it and make it not function properly. And as I said at the beginning, after 96 hours, you should change to an active humidifier. And of course, the airway, we're monitoring the airway. So the endotracheal tube, there's a lot of things we need to look at when we check the endotracheal tube. One, we want to look at the position and the depth. You want to see, if it's on the left side of the mouth or on the right side of the mouth, and we should change it from the right side to the left side to the right side of the left pretty frequently. Your hospital may have a policy, every 4 hours, switch it back and forth. The more often, the more comfortable it's going to be for the patient. And the depth of the tube. You can look and see numbers on the tube in centimeters, and you see it says 23 at the teeth. Well, that should be documented. So if you have a problem with the ET tube and you think, well, did it come out or did it go down too far? And you know, because everybody's been documenting that it's 23 at the teeth, that isn't the problem. But if you see it's 20 at the teeth and it's supposed to be 23, then you know that the tube has changed its position. It can go down, and if it goes down, it tends to go down into the right main stem, and that causes serious problems. So we want to document that the position is on the right side of his mouth, and it is 23 at the teeth, not at the lip. You'll see some people chart it that the ET tube is 23 at the lip. The lips swell and move, and you know, that's not as consistent as at the teeth, because the teeth stay where they are. You want to check the patency of the ET tube. So you put your suction catheter down, and you should not feel a point where it gets sticky, where it gets harder to pass the tube, past the catheter. That catheter should go down easily all the way to the end of the tube. And when you feel it, a point where you're going down where it gets difficult, that's something happening to the patency of the tube. Now, it could be a lot of things, and to help figure out that, you can just pay attention to where the tip of the tube is. As you start to go down the tube, if you feel that obstruction almost right away, that could be that the patient is biting on the tube, and that's not an uncommon problem. Now, it could also be that the patient is not biting on the tube, but he was biting on the tube earlier and left that indentation in the tube, and then the catheter won't pass through there very easily. If you get past the teeth and it goes down easily, but just a few inches past the teeth, you feel the obstruction. That could be that the tube is kinked in the back of the guy's throat where it makes that turn. Not very often that you'll see that. And usually when you have that kinking in the back in the oropharynx is when they have a small ET tube. So, you know, the ET tubes are pretty rigid, but when you put it inside the patient, it warms up to body temperature. It gets a little more flaccid, and they can kink, especially a size 7.5, 7 in smaller ET tubes. If you get past that point with your suction catheter and it's going down easily, and toward the end of the tube it gets hard, that's usually the crusting of the ET tube. Those are dried or thick secretions that have accumulated down at the distal end of the endotracheal tube. Cuff pressure, we need to measure the cuff pressure. The cuff pressure can cause the patient to have tracheal damage if the pressure is too high. If the pressure is too low, you have leaking some of his tidal volume out. Also, part of the reason why we have the cuff on the ET tube, it helps to prevent some of the secretions from the mouth and the nose going down into the trachea. So we want to have that set appropriately. And what we want to set is between about 27 and 34 centimeters of water pressure. The lower, the better. That's 20 to 25 millimeters of mercury if you're checking it with something that tells you in millimeters of mercury. And the reason why that you don't want to go higher than that is because the capillary pressure in the tracheal wall is 20 to 25 millimeters of mercury. So if you exceed, if the cuff pressure exerts pressure on the wall that exceeds 20 to 25 millimeter mercury, you stop blood flow. You stop oxygen delivery, and then you have damaged or even necrosis of that tissue. And remember, the back of the trachea has no tracheal ring, so that where you have this erosion, this necrosis, would be back there, and that's right adjacent to the esophagus. So you can have a tracheoesophageal fistula occur from having that pressure too high in the cuff. Now, that's normal pressure in the tracheal capillary bed. But what if the patient's hypotensive? Well, then that pressure will be even lower. So what we want to do is we want to use the cuff pressure that is maintaining a seal, but not too high, and we don't want it too low. And the patient may not have an endotracheal tube, he may have a tracheostomy tube. And there's some things you need to be aware of with the tracheostomy tube. If it's a fresh trach, then it can be painful. So you will want to make sure you really avoid traction on the tracheostomy tube. And again, you want to make sure it's patent, that there's no obstruction, and that it's secure. With a tracheostomy tube, the patient can cough and cough the tube out if it's not secured good. We usually don't trach patients who are requiring high pressures from the ventilator to ventilate them, because again, that tries to push that tube out. So we want to be very concerned about the patient's comfort. We want to check and make sure the cuff pressure is appropriate in our tracheostomy tube, just like with the endotracheal tube. And we want to make sure it's clean. You may be working in a hospital where the nurse does the trach care, and it may be where you do the trach care. But if you see a lot of secretions around the stoma, and the gauze is soaking wet with secretions, you can clean that, you can change that, even though it's not time for your scheduled trach change. So you want to keep that clean. You want to look at the stoma. If you see redness around the stoma, what does that mean? Right, infection. So making sure that you don't see any redness or pus or anything around the stoma is very important. So tracheostomy tube is a little bit different monitoring than the endotracheal tube. Okay, now, as we started this, I said, you want to think that you're not just monitoring the ventilator, you're also monitoring the patient. So you're going to want to communicate to the patient, ask him how his breathing is. You can say, do you feel like the machine is helping you breathe enough? Or, questions like that. The patient can often tell you a lot more than all those numbers on the machine. You may have patient's family in the room when you go in there, and it doesn't take long for the patient's family to know that you're involved with that machine, and that's the life support, and they're going to, want to perhaps be asking you a lot of questions. And you have to be careful when you're talking to patient's family and not give them false hope or any misinformation or something that they're, not required to know about. And so you might want to say, you have to ask the nurse about that, or ask the patient's doctor. And sometimes, you can talk to the patient family, get to know them, and have discussions with them and stuff, but just be careful about giving a family any kind of false hope. Oh yeah, he's doing really good, when he's not. And refer them to the nurse or the doctor. They know how to answer some of those tough questions that the patient's family may be asking you. Of course, you want to communicate with the nurse. You go in, you want to know if what's the plan, and the nurse said, well, we're going down to CT scan an hour. Well, that's good to know, because you can get your transport ventilator ready, or, some condition that changed in the patient or whatever. So the physician probably isn't going to be in the room. Nurse very likely is. But it's important to communicate with the physician what the plan is, what we're trying to do with the patient, and understand all of the patient's problems. And so having communication with the patient's doctor is important. You want to look at the patient's position. Is he all scrunched down in the bed? Does he need to be lifted up? Is he and way over to one side and kind of stuck down between the rail and the mat, all kinds of things that you see. Also today, we know that patients almost always need to have the head of their bed elevated 30 or 40 degrees. So the nurse may have laid the bed down while she changed his bedding or something like that and didn't raise him back up. So, you want to make sure the patient is in a proper position, a good position for breathing and comfort, and not in any kind of dangerous situation. And of course, you want to listen to his lung sounds bilaterally. You listen to one side and compare it to the other. You're listening for things like no breath sounds on the left side, which would happen if the ET tube migrated down the right main stem. And you're listening to see if he sounds like he needs to be suctioned. So you hear rhonchi, bubbling, gurgling over the large airways. You suction him if he needs to be suctioned. And you want to listen for like crackles in the bases or wheezes and all the kind of stuff that you would listen to anybody's lung sounds. Every time you go check your vent, you should always be listening to the patient's lungs. And you want to look at the patient's breathing pattern and assess his work of breathing. If a patient looks like he's working too hard to breathe, he is. And we know now that the work of breathing doesn't have to be very high to be at a fatiguing workload. And you don't want the patient to have respiratory muscle fatigue, because when their respiratory muscles are fatigued, they can't ventilate adequately. We want to look at the patient, see if he's showing any signs of distress, if he seems to not be synchronous with the ventilator. Sometimes it helps to put your hand on over the patient's abdomen and watch the ventilator and feel the patient's breathing at the same time, and you can tell sometimes that the patient and the ventilator are not in sync. You always want to know what his vital signs are, his O2 sats, his blood pressure, and heart rate and all that kind of stuff. If he has a central venous line in, you want to know what his CVP is. You want to check the patient's restraints. Their hands should be tied down. You don't want it loose enough so he can reach up and get his ET tube. And if you have to do something with the patient where you undo his restraints, you want to make sure you tie him back up. I mean, you might be doing chest physiotherapy on the patient and have to untie one hand to turn him over on his side, and you must not forget to tie him back down. If he self-extubates, that would be your fault. And of course, we talked about this at the beginning, the urine output. Is he making urine, and what does it look like? And you should always know what kind of sedation the patient's getting. Is he paralyzed? Is he sedated with benzodiazepines? Is he getting morphine? All of these kind of things that is important to know about your patient on the ventilator. Now you're done. You're going to go and document all of this information in the EMR. And now the EMR, there's 3 sections. The first section is what is said on the ventilator. And as I said earlier, that needs to be what is exactly the doctor's order and what you document. Those 3 things need to be exactly the same. What's said on the ventilator, what you document, and the physician's orders. Then the second section is what is measured or analyzed. So, for instance, they may not be the same as what's said on the ventilator. You may have a patient in assist control, and on the ventilator, he's getting 14 breaths per minute. That's set on the machine. But he's breathing and triggering more breaths, so he's actually breathing 22 breaths per minute. So in the first section, you would chart what is actually set. The second section is what you actually see the patient doing. Or analyze. Of course, that would be your oxygen analyzer. You got it set at 40%, and you chart that O2 is analyzed at 40%. And all the alarms. You want to make sure you document the alarms to be set appropriately. If the patient is being ventilated with 20 centimeters of water pressure, and you document that the high pressure alarm is 50, then that's not right. That's not good. And you remember, this is a permanent documentation that you're making. And so later there's some kind of a lawsuit or something, and they look and they see that you had the alarm set inappropriately. That might not be good for you. So set the alarms according to your department's policy above and below what the patient's actually doing. And there are places for you to make notes and comments, and that's important for you to note anything that you think might be pertinent. Also, with electronic medical charting, there would be a way for you to communicate with the pharmacist or the physician. So you can write a dear doctor note that the patient is still on assist control, and you think that he could start reducing his ventilatory support because he's getting a lot better, and move toward getting him extubated. Or that you note that he might need more ventilatory support. He might be better off with a different mode of ventilation. Any kind of things like that. That's real important for you to note. Also, you have an alarm that is set appropriately, but the patient's real agitated, coughs a lot or whatever, and he sets the alarm off all the time, and you got a nuisance alarm. But you don't want to set it too high, because you could get in trouble for having the alarm set too high, as I just said. But sometimes you have to set the alarm higher than what is recommended. And if you do that, that's okay, but you just want to make sure you make a note that you set the alarm higher than the protocol, but you also explain why you did it. And again, recommendations, you call the doctor if you need to, and recommend ventilator adjustments that might need to be done that would benefit the patient. A very important part of a respiratory therapist's job is making recommendations. And it's very important with mechanical ventilation. The doctor's not at the bedside all the time, not seeing all the stuff that you're seeing. So you need to be in good communication with the doctor and working with the doctor to provide the best care for the patient. And that's the end of this